Good morning. Welcome to the Blue Cross Blue Shield of Massachusetts Foundation webinar focused on state health planning in Massachusetts. My name is Caitlin Kenny Walsh, and I'm the Vice President of Policy and Research at the Foundation. Thanks for joining us here today. I will provide you with an overview of today's webinar and introduce our speakers momentarily. But before we officially kick off, I want to go over a few housekeeping details. We are using the mute feature on the audio line during this webinar to reduce background noises. We encourage your participation and we will be taking questions. Please feel free to submit questions during the webinar. We do have a dedicated time for Q&A and we will get to them then. To submit a question, please click on the Q&A icon located at the bottom of the Zoom window. We will try to answer as many questions as we can. This webinar is being recorded, and in the next few days, we will post a link to the recording and a copy of the webinar slides on our website. Next slide, please. So, what can you expect in today's webinar? I will begin by providing you with some background on the Foundation to orient you to who we are and how we do our work, and to provide some context into how the topic of state health planning relates to our mission and focus areas. Then I'll turn it over to Bob Seifert, a consultant in healthcare policies and programs, and the author of the issue brief that is the impetus for this webinar. Bob will help ground us in what is meant by state health services planning and provide a brief history of health services planning nationally and in Massachusetts before reviewing the existing tools in place today that are related to state health planning. Following up on Bob's remarks, we will hear from Cara Vidal, the director of the new Office of Health Resource Planning, OHRP, at the Massachusetts Health Policy Commission. Cara will provide us with an introduction to some of the key responsibilities of the OHRP, another new acronym for the Massachusetts Health Policy Community, and she'll talk about how it will focus its work over the next couple of years. We'll pause there and take some time to answer your questions. I'd like to ask that we move to the next slide, please. Pictured here are the speakers on today's webinar that I recently mentioned in reviewing the agenda. We are grateful to have Bob Seifert with us here today, who has expert knowledge of Massachusetts health policy, programs, and systems, and a unique ability to make some of the most complicated and complex topics understandable. We are also thrilled to have the inaugural director of OHRP, Cara Vidal, with us. She too brings a wealth of knowledge of the Massachusetts healthcare policy and systems landscape. Next slide, please. So, for those of you not familiar with the Foundation, we are a nonprofit organization, and the mission of the Foundation is to ensure equitable access to healthcare for all those in the Commonwealth who are economically, racially, culturally, or socially marginalized. We organize our work in support of this mission in three main focus areas: care and coverage, behavioral health, and structural racism and racial inequities in health. And you can see this depicted in the circular graphic on the left. Today's webinar could theoretically encompass all of these, but at the highest level, we think of it as situated in our coverage and care focus area. As a foundation, when we think about how we seek to advance this mission, it really comes down to relying on three different strategies. We produce and disseminate timely and objective policy and research work that raises visibility of particular issues and informs the public dialogue, including with solutions to existing challenges. We identify and invest in strategic grant-making opportunities that allow us to test and analyze solutions, and we host programs and convenings, including webinars like this, to share policy and research findings, disseminate best practices, and learn from the community about ways to foster movement towards our mission. So, with this context on who the Foundation is, how did that bring us to a report on state health planning tools and processes in Massachusetts? Next slide, please. While all of us from Massachusetts appropriately take great pride in our health insurance coverage rates, we've learned from experience over the last few years that these high coverage rates certainly don't equate to access to healthcare services. I'll be referring to some data from the Center for Health Information and Analysis's Health Insurance Survey from 2023, which is before many of the recent closures we have seen in our healthcare landscape. Therefore, I suspect it underreports the access challenges experienced by Massachusetts residents. Nonetheless, according to that data, While most residents have a usual source of care in Massachusetts, 2/5, over 40%, reported having difficulty accessing care, and over a quarter report difficulties getting an appointment as soon as they needed. This is causing people to present at emergency rooms, with well over 1/3 of people who reported going to an emergency room in the last 12 months going for a non-emergency condition. We also know that there are persistent inequities with respect to access to care. Previous research from the foundation has demonstrated, for example, a disproportionate need for behavioral healthcare services among people of color, and other research we have done has made clear that when seeking services, particularly for mental health conditions, people prefer a provider who shares their racial, ethnic, or linguistic identity, and we know that many of those who have sought care have struggled to find a provider with whom they can relate in this way. Costs in Massachusetts, even when one has health insurance, continue to be a major problem. Over 40% of Massachusetts residents report that they or a family member had issues affording health care. When we look at this by race and ethnicity, we see this is significantly worse among non-Hispanic Black residents, where almost 50% report affordability challenges, and among Hispanic residents, where almost 60% report affordability challenges, as compared to less than 40% for non-Hispanic whites. And of course, we need to acknowledge that the healthcare system landscape has been very volatile. In 2023, we saw a fire destroy Signature Healthcare's hospital in Brockton and the closure of Compass Medical practices. In 2024, we experienced the financial collapse of the Steward Healthcare system and related closures of Kearney Hospital and Neshoba Valley. This volatility and associated closures have undoubtedly had compounding effects on the access, cost, and equity challenges I just mentioned. It is against this backdrop that the need for an active, intentional state health planning process and system became increasingly clear. To help inform the development of such a system and supporting processes, the Foundation commissioned a primer to lay the groundwork of how state health planning is defined, how it has evolved over time, and to serve as an educational resource on the existing tools in place in Massachusetts that might be leveraged and built upon as the Commonwealth, led by the Office of Health Resource Planning, moves forward in a more formal state health planning endeavor. And with that as context for today's webinar, I'd now like to turn it to Bob Seifert.
Caitlin, thank you. And thanks also to you and to Jesse and the Foundation for the opportunity to research and write the issue brief and to participate in the webinar today. And good morning, everyone. I am going to start with defining a key term. What do we mean when we say health services planning or simply health planning? There are many variations, but this one on the slide emphasizes key features of matching population needs to available resources and looking at both the current and future needs and anticipated resources. So our definition is health services planning is a process that appraises the overall health needs of a geographic area or population and determines how these needs can be met in the most effective manner through the allocation of existing and anticipated future resources. Next slide, please. Why should we consider a state-led process of health planning? Health planning provides a formal mechanism for allocating scarce resources equitably and effectively. Participation by a broad array Participation by a broad array of stakeholders makes it more likely that planning will focus on priorities that are community-driven and in the public interest, such as improving access for specific underserved populations. It assures community participation in priority setting and planning alongside the major market participants, providers, payers, and the state, whose action typically have the greatest impact on resource allocation. Planning offers a venue for getting issues out on the table, promotes discussion of the issues, and a framework and common context for decision-making. Planning might also promote cost containment or address access concerns through greater emphasis on coordination, efficiency, and accountability. There also are many challenges to doing effective planning in a healthcare system that is as decentralized and market-oriented as ours. One is that planning needs to happen in a system that continues to operate and evolve, where innovations are happening, the economy is shifting, and so on. So the process must be a dynamic one to take this into account. Second, stakeholders may have their own priorities and objectives that conflict with others. For example, providers may not have a business incentive to coordinate, and consumers are not motivated by typical incentives because they usually do not directly pay the full cost of the services they receive. The planning process is also at least partly political and subject to power dynamics, which might leave it open to criticism among participants who do not like the results. And last, planning needs to be an ongoing process, which requires sustained commitments from its public sponsor and the other participants. This is a challenge in an environment with many other important issues competing for public attention and resources. Next slide. I want to give you an extremely truncated history of health services planning nationally and in Massachusetts. There is some more detail on what I'm about to cover in the published issue brief, which we linked to earlier in the chat. The main points I want to bring out from this timeline are, first, that health services planning has a long history, stretching back about a century in the United States to a time when medicine was being solidified as a profession. The second point is that the most significant early planning initiatives were designed to promote the expansion of healthcare services. In the case of the Committee on the Costs of Medical Care in the late 20s and 30s, the committee's studies of access equity and the distribution of the medical dollar concluded there were insufficient levels of medical care across the country, regardless of one's income. The committee called for increased investment of national resources in medicine. Later, the Hill-Burton Act, formerly called the Hospital Survey and Construction Act of 1946, supported hospital construction and expansion with an emphasis on rural communities. The mechanism for doing this was through state construction grants to hospitals distributed according to states' needs as measured by state-conducted surveys. In contrast to these early planning initiatives focused on expanding access, the National Health Planning and Resources Development Act of 1974, also known as NHPRDA, was responding to the escalating costs of healthcare through the 1960s and early 70s. This was the first major planning effort focused on containing costs rather than on promoting growth. The main mechanism was the management of capital expenditures through a Certificate of Need process, or CON. The act required states to adopt a CON program and created a planning infrastructure of state health coordinating councils and about 200 local health systems agencies across the country. Unfortunately, NHPRDA was largely unsuccessful in restraining costs. CON and the regulation of capital expenditures were not up to the task of regulating costs, nor were the other tools and infrastructure the law created. The law fell into disfavor and was repealed in 1986 as market-imposed discipline became the norm. Massachusetts' experience with health services planning mostly parallels the national experience, with a state-guided process and local planning efforts largely, though not completely, later supplanted by market forces. Massachusetts adopted a Certificate of Need process in the 70s as federal law required. In Massachusetts, it is called Determination of Need, or DON. We also had a hospital rate setting system that was intended to contain costs. Massachusetts retained its DON rules even after repeal of the NHPRDA in 1986, though it eliminated hospital rate regulation in the early 1990s. Next slide, please. Today, determinations of what healthcare services will be delivered, where, and at what price are largely made in the healthcare market through the decisions and interactions of providers, private and public payers, employers, and others, with some regulatory oversight by the state and federal governments. But market-driven decisions do not meet everyone's healthcare needs, and access challenges persist for certain populations and certain types of care, as Caitlin noted earlier. But while health services planning as an organized, state-driven process has faded from public policy, Massachusetts has kept alive through various initiatives the importance of understanding healthcare needs across communities and populations and encouraging the healthcare system to meet those needs. For example, an early initiative was the creation of 27 community health network areas in 1992. The CHNAs, as they were known, comprised all of Massachusetts cities and towns and were tasked with assessing community health, identifying needs, and supporting initiatives. The Attorney General's office also established community benefits guidelines for nonprofit hospitals and HMOs in the 1990s and updated them in 2018. The guidelines include expectations that the hospitals and HMOs conduct a community health needs assessment every 3 years. Additionally, Massachusetts updated its DON rules to mandate investments by applicants in community health initiatives that address health inequities. I'll talk more about that in a few minutes. And Chapter 224 of the Acts of 2012 created the Health Policy Commission, the HPC, and the Center for Health Information and Analysis, CHIA, which I will call it from now on, with mandates to address rising healthcare costs. So there remains an instinct for health planning in the public interest in Massachusetts, but the Commonwealth does not have a system-wide comprehensive approach. However, there are building blocks that could support a health planning revival. Let's now look at some of them. Next slide, please. The issue brief identifies several existing programs and policy tools in Massachusetts that address health needs and resources in a variety of ways. The tools are organized into 5 categories: tools that address the allocation of resources, population health, the healthcare workforce, healthcare costs, and business transactions. The summaries in the issue brief and that I am about to present here are based on a landscape scan of publicly available information on agency websites and in state laws and regulations. I will look at each category of tools in turn, describing some examples of each, and more information about all of the tools is in the issue brief. Next slide, please. The first group of policy tools are those that attempt to understand and match community healthcare needs with resources. One example is Massachusetts' long-standing determination of need law. Facilities such as hospitals, clinics, and long-term care facilities must apply for a DON when they are planning a substantial capital expenditure or a substantial change in services, or when pursuing original licensure, a transfer of ownership, or a change in site. The DON applicant must demonstrate that its proposed project meets a need among its patient panel. For example, that building a satellite clinic or introducing a new specialty service is responding to documented needs of its patients. Additional DON approval factors require demonstrating that the project will contribute to the Commonwealth's goals for cost containment, improved public health outcomes, and delivery system transformation. Importantly, the applicant is also required to fund a community-based health initiative that addresses a state health priority. The initiative must be approved by the Department of Public Health, DPH, for the DON application to move forward. The health initiative must be locally planned and implemented, and there is a minimum funding requirement of 5% of the total capital expenditure proposed in the DON application. These DON rules make the process more responsive to broader community health considerations, and in that sense can be an effective tool for health services planning as far as it goes. But DON is by its nature somewhat narrowly focused. The DON process is only prompted by a healthcare provider's application to make a substantial capital investment, and the DON factors I described focus on the applicant's patient panel, not necessarily the entire community. It also does not look ahead to project future healthcare needs. A second example in this category is the new Office of Health Resource Planning at the Health Policy Commission, and we will hear from Kara about OHRP shortly. Next slide, please. A second set of tools helps identify public health priorities at the state or community level and then supports the development of initiatives to address the priorities. One example is the State Health Assessment Tool, which is an online compendium of publicly available data that communities can use to analyze public health needs. Another example is the Attorney General's Community Benefits Guidelines, which I mentioned earlier. As part of their responsibilities to the communities they serve, under the guidelines, nonprofit hospitals and HMOs complete a community health needs assessment at least every 3 years. A third example is community health improvement plans, which I think are a somewhat lesser known tool. These plans are long-term efforts to improve the health of a defined community. They are funded through grants from the Massachusetts Community Health and Healthy Aging Funds. DPH maintains these funds, and the nonprofit organization Health Resources in Action, or HRIA, facilitates the grant application process and makes funding recommendations to DPH. Funded improvement plans often focus on root causes of health and on social determinants of health, which means that the projects may reach beyond the healthcare system to other environmental factors that affect health. The Community Health and Healthy Aging Funds have funded 16 community health improvement plans across the state over 3 funding rounds in 2020, 22, and 24. Grants average $375,000 for periods of 3 to 5 years. While this represents important support to communities trying to improve health and health equity among their residents, the tool is very locally focused, and grantees do not cover all of Massachusetts. Next slide, please. Workforce gaps, of course, are a major concern in Massachusetts and across the country. They bear significantly on the capacity of healthcare providers to meet communities' needs. There are several initiatives in Massachusetts that identify workforce challenges and make policy and programmatic recommendations to reduce them. CHIA has begun conducting a biannual survey to monitor trends in the Massachusetts healthcare workforce. DPH's Healthcare Workforce Center administers the Massachusetts Loan Repayment Program for health professionals. And one of the newest planning-related initiatives in Massachusetts is the Behavioral Health Workforce Center, which was launched by the Health Policy Commission and the Executive Office of Health and Human Services in September of 2024. This center is an acknowledgement of the challenges of capacity and turnover in the behavioral health workforce and the effects of these challenges on access and outcomes. The Behavioral Health Workforce Center will identify challenges, monitor trends, convene stakeholders, conduct research, and make policy and programmatic recommendations. The center's initial research will focus on rates paid for behavioral health services, on establishing baseline behavioral health workforce needs, and on the licensure and certification processes for the behavioral health workforce. The center will receive expert input from a 31-member advisory group representing a broad range of stakeholders. This level of attention to identifying workforce deficiencies and developing approaches to removing them is essential to a health services planning process. Next slide, please. As I mentioned earlier, Chapter 224, enacted in 2012, created the HPC and CHIA so that they would monitor healthcare spending for the purpose of bringing it into line with overall economic growth. The HPC and CHIA deploy several tools to do this. The best known is probably the cost growth benchmark, which the HPC sets as an annual target for the rate of growth of total healthcare expenditures. The benchmark is based on CHIA's analysis of expenditures in the most recent year for which it has data, and an input from a public hearing that the HPC holds in collaboration with the legislature. Participants in the hearing consider data, expert testimony, and other information bearing on healthcare costs. After the close of the year, CHIA looks at expenditure data to assess providers' and insurers' performance against the benchmark. HPC issues its annual cost trends report in the fall and holds the annual cost trends hearing. CHIA may also make confidential referrals to the HPC of providers and health plans whose spending growth exceeded the benchmark. The HPC has authority to require such entities to implement a performance improvement plan to bring its spending back into line with the benchmark. CHIA now also publishes reports on trends in spending for primary care and behavioral health services, which are key indicators of whether healthcare resources are supporting a well-performing system and meeting communities' needs. This group of tools, hearings, reports, and the benchmark, could be a central focus of a comprehensive planning process. The tools focus primarily on costs, which of course a legitimate planning process must do, but the analysis, reports, and hearings that are part of the cost trends platform can also surface access and equity challenges across the population. They can be combined with other information, for example, about community health needs and provider supply to inform health services planning. Next slide, please. State rules require healthcare provider organizations to notify the HPC about significant changes in operation or ownership. Hospitals also must notify DPH about plans to close an essential service so that it can evaluate its impacts on the community and the healthcare system. An essential service in this context is almost any service a hospital is licensed to provide: ambulatory care services, birth services, medical surgical, intensive care, psych services, reproductive health services, and so on. The HPC requires providers and provider organizations with more than $25 million in revenue to notify it of material changes. The definition of a material change includes capacity expansions and mergers with or acquisitions by other healthcare providers. And as of this year, material changes also include transactions involving a significant equity investor and real estate leaseback arrangements. Not coincidentally, these are the types of transactions that characterize the history of Steward Healthcare in Massachusetts and contributed to its financial collapse. Following an initial review of a material change notice, the HPC may decide to conduct a full review called a cost and market impact review. The purpose of the review is to evaluate the impact of proposed changes on the Commonwealth's ability to meet the healthcare cost benchmark and to look at impacts on the competitive market, which includes the consideration of access issues. The HPC does not have authority to block a transaction, but it can refer a transaction to the Attorney General if it finds that the transaction will adversely affect the market or increase costs. The HPC has conducted 10 full cost and market impact reviews in its history and has made 4 referrals to the Attorney General. Cost and market impact reviews are forward-looking by design. The HPC tries to project the impact of a material change on future access costs and quality. This is a tool that could support a broader health planning vision by providing market oversight tied to statewide goals and priorities. Next, please. So we've had a brief tour of several tools that could be components of a comprehensive state health planning process. Some of them interact in ways that suggest the potential for building a more complete structure. For example, the tools identify community needs in a number of ways, which is essential to health planning. The DON process, community health needs assessments under the community benefits guidelines, and community health improvement plans all identify community health needs. These locally focused needs can be aggregated to provide a picture of regional or statewide health and healthcare needs. Second, the DON process itself gives rise to local community health initiatives and to community health improvement plans across the state. Third, there is an abundance of data that can be used for planning. The State Health Assessment Tool, CHIA's array of workforce and healthcare cost growth data, provider cost reports, hospital profiles, many other sources of data. And fourth, DPH's essential service closures process and the HPC's cost and market impact reviews can raise red flags about pending changes in healthcare resource allocation. So we have some building blocks, but these tools are not part of a coherent and interactive health planning system. The use of the tools is not guided by overarching statewide goals, and many needs assessment efforts are led by private rather than public entities. While there are many community-driven health improvement efforts, a global perspective on what is needed is lacking. There is not a statewide plan for monitoring and reporting on progress toward goals, and most current tools are in fact mainly concerned with the present and are not particularly forward-looking. Next slide, please. This brings us to the speculative portion of our program. If stakeholders in Massachusetts thought it wise to move toward a more organized health planning environment, how could it build on the existing tools to do that? The issue brief offers a few high-level suggestions, including, first, there is a need for clearly articulated statewide and regional goals concerning the distribution of healthcare resources, goals that reflect public priorities around access, equity, quality, and outcomes. One example of a high-level goal is in the recent law that created the OHRP, quote, promoting the appropriate and equitable distribution of healthcare resources across geographic regions, unquote. More granular goals might include, for example, preventing chronic and communicable diseases and promoting healthy women, infants, and children. The goals would be widely disseminated and reinforced through the policies and activities of state agencies and would guide decisions around expansions in healthcare resources. Second, there should be a structure for developing, implementing, and monitoring a state health plan and statewide priorities. Such a structure should include requirements for how frequently the plan and priorities should be updated. The structure should also provide for equitable contributions from all stakeholders and should include and give strong voice to local communities. Third, the process should be oriented to meeting future needs in addition to responding to current concerns. And fourth, planning should include a focus on the healthcare system beyond hospitals. Some of today's tools are indeed broader in scope, but many high-profile state activities such as DON, community health needs assessments, and cost and market impact reviews are still largely about hospitals. We have a history of state health planning to learn from and an incomplete set of tools to build on. We also now have a new Office of Health Resource Planning at the HPC, which seems to have been created with at least some of these planning principles in mind. So having given you this background, we will now turn to hearing more from Kara Vidal from the HPC about the plans for standing up that office. Thank you very much.
Thank you, Bob. Thank you for that excellent overview. And good morning, everyone. My name is Kara Vidal, and as Bob said, I'm the director of the Commonwealth's new Office of Health Resource Planning within the Health Policy Commission. First off, I just want to thank the Blue Cross Blue Shield Foundation for inviting us to participate in this webinar. Good health planning will require participation and partnership from across the Commonwealth, so we're very excited to be building those relationships right out of the gate. Next slide, please. So as the brief lays out, Massachusetts ranks highly on several measures of healthcare outcomes and healthcare access. It also ranks highly in terms of our per capita healthcare supply levels, in particular for primary care physicians, specialists, behavioral health clinicians, and hospital beds. However, Those resources are not distributed equally across the state. Suffolk County in particular tends to have much higher supply rates. And we also know that physical proximity to healthcare resources is not the same as having access to those resources. And as Caitlin described for us in her introduction, Massachusetts residents often face barriers when they have to access care. Additionally, despite the fact that we are a high resource state generally, the supply and distribution of our resources is in constant flux. Caitlin mentioned several recent sudden changes affecting both hospitals and provider groups that have occurred in Massachusetts. We have also seen expansions in inpatient services and the impending construction of a new oncology hospital. We have a strained primary care system and increasing hospital length of stay that is putting pressure on emergency department capacity. And as Bob just laid out for us, Massachusetts has some tools to track these changes and sometimes address them, though as he noted, they're often tailored to a specific set of questions about a specific change. And they leave unaddressed larger questions as to how our healthcare resources are shifting and how those changes are impacting equitable access to affordable, high-quality healthcare over time. Next slide, please. So to help provide that big picture assessment, the legislature established the new Office of Health Resource Planning. I heard OHRP before. We've been going with OHARP internally, but all acronyms welcome within the HPC. So the office has three specific functions under the law. First, it must develop a state health resource plan. Second, it can conduct focused assessments that look at a single service line or a single geography. And third, it must conduct at least one annual public hearing. Additionally, though this is not required by the law, OHARP will also be managing the existing Massachusetts Registration of Provider Organizations program, which we call RPO. RPO is a data collection and transparency effort that was established under Chapter 224, and it tracks key data on the structure, relationships, and finances of large provider organizations in the Commonwealth. Those data will be a key input into the Office of Health Resource Planning's work. They are a key input into the Health Policy Commission's work generally. So we expect staff for OHARP and RPO to be closely integrated. Next slide, please. As laid out in the law, the overarching goal of the State Health Resource Plan is to promote the appropriate and equitable distribution of healthcare resources across geographic regions of the Commonwealth. So specifically, that will include identifying anticipated healthcare needs, existing resources available to meet those needs, and then assessing alignment of needs and resources. And that can be done both in a current state as well as projecting out into a future state. The plan should also include recommendations for the appropriate supply and distribution of resources and recommendations for any further legislative action. I think this hits all of the key elements of Bob's definition of what constitutes health service planning. If we could go to the next slide, please. Thank you. The statute is also clear that the recommendations in the State Health Resource Plan should support the Commonwealth's broader policy goals. They're listed here. I won't read them all to you, but they speak broadly to themes of access, cost, equity, integration, and innovation. Next slide, please. The first State Health Resource Plan is due to the legislature by January 1st, 2027. So that gives us about a year and a half to scope, execute, and interpret our analyses. So as we start thinking about the scope of that first report and what questions we want to ask and answer, we're cognizant of how complicated and nuanced this work is, and of the responsibility that we have to the residents of the Commonwealth to develop robust methodologies that can account for some of that complexity. I have a few examples on the slide here. There are many more. For example, when we think about supply, we know we'll of course need counts of clinicians, counts of facilities, counts of technologies. But we also need to marry that information with capacity data. For example, knowing that you have 10 clinicians in one area of the state, if you don't know whether each of those 10 clinicians is working full-time, part-time, or 1 day a week, does not necessarily serve your planning purposes. When we think about need, which is depicted a little bit here on this graphic, which I really like and will not try to go letter by letter here. But many health planning efforts in the past have started with utilization as a proxy for need, and that's a reasonable place to start. But we also want to think about why our utilization levels could represent overutilization, for example, low value care that possibly did not need to be delivered, or inefficient care, so care provided at higher cost settings when it could be provided in a different, more efficient setting, as well as potential underutilization. We know that there is care that is needed but is not received. And so how can we account in our methodologies for that as well? We also want to think about access barriers and how that intersects with healthcare supply and resources. For example, we'd like to ask questions like, what problems could be solved with more clinicians, for example, versus what problems could be solved with extended office hours? And then finally, we just want to be very cognizant of the fact that a lot of these questions and complications that I've just laid out for you really need to be looked at in the current state analysis before you can get to the question of projection. Because if you have utilization that doesn't reflect need at baseline and you don't account for that at baseline, you'll simply project that into the future. Next slide, please. Okay, on these last two slides, we wanted to give you a sense of what OHARP will be working on for the next year and a half. And we've organized our work into three main buckets: strategic planning, health planning, and data planning. In the strategic planning space, we're working on defining goals, timelines, work plans. We're working on staffing and stakeholder outreach. And in particular, we want to think about community engagement and how we can make sure that this plan captures the priorities and preferences of Massachusetts residents. In the health planning space, we're wrestling with some of those methodological questions that I just described. We are drafting out a scope for the state health resource plan, and we're also supporting the Massachusetts Maternal Health Access and Birthing Patient Safety Task Force, which I will mention in slightly more detail on the next slide. We're also considering what service lines might be a priority for any focused assessments that the office undertakes. And then finally, in the data planning space, we are working on assembling key data resources, identifying key data gaps, and developing approaches to fill those gaps. We are gearing up for the 2025 RPO data collection filing, and we are working on advising DPH on the development of their healthcare resource inventory. Next slide, please. So as our first piece of analytic work, we are supporting, as I said, the Maternal Health Access and Birthing Patient Safety Task Force. That is a 9-member task force. It was established by Chapter 186 of the Acts of 2024, and it is co-chaired by the Health Policy Commission and the Department of Public Health. That task force is charged with looking at past essential service closures for maternity units and birthing centers, ambulatory service closures, quality and safety implications of these closures, and demographic information on those most impacted by the closures. So we are very proud to be supporting this important work, and we are using this as an opportunity to start to pilot some processes and methodologies that we can use in the development of the larger state health resource plan. That is all I have for today, so I will hand it back over to Caitlin.
Thanks, Kara. Thanks, Bob. We really appreciate all of your remarks. We do have a few questions that have come in that I would like to pose to each of you. One of the first questions that I have, we have a couple comments actually around community health needs assessments, including one question bordering comment, but I think merits addressing, that it's someone's understanding that community health needs assessments are no longer in existence, and that these were once an important opportunity for communities to define their needs. So I wonder, Bob, based on your research, if that's a question that you could address for us.
I wonder right back at you, Caitlin. What part of the problem with doing this work is that there are only 26 letters in the English alphabet, and CHNA can stand for Community Health Needs Assessment or Community Health Network Areas, which I mentioned in my presentation, and it's in the brief as being the 27 local areas that DPH created in the early 90s to do health planning really at a local level. Community health needs assessments are still done on a regular basis in a lot of different contexts, as I mentioned, under the DON process and certainly within the community benefits guidelines that hospitals and HMOs are following. The CHNAs, the community health network areas, are no longer supported by the DPH structure. Some of the groups that formed as CHNAs still exist in some capacity and are doing some work, but there's not the centralized sort of structure and coordination that DPH provided for them. So yes, I agree that sort of local structure, the local planning is really important and can be sort of built up to become a regional or statewide effort. There are other things that have replaced it over time, but the CHNAs themselves are no longer functioning as such. Thanks.
Thanks, Bob. Appreciate that. And also highlighting the challenge of the many acronyms in the healthcare policy language. Kara, I definitely think we will take up OHARP instead. It rolls off the tongue a lot easier. And we do have a question that came in for you. And the question there is, in its work, will OHARP intend to be inclusive? Will aging seniors and rural geographies be included in the tools assessing access to health services? How will we think about different geographies like Western Mass? Can you share a little bit about what the tools will be and the geographies of focus will be as part of the work moving forward?
Yes, happy to. Thank you. That's a great question. So I think broadly, the answer is yes, absolutely. We will want to take into account the special needs, circumstances that a specific population may face, that a specific geography may face, for example. And I do think this might be a helpful moment to talk about some of the relative merits of our State Health Resource Plan, which is the large plan that is intended to encompass the system broadly, versus a focused assessment, which we also have the authority to do under this law. The State Health Resource Plan, as I mentioned, is meant to be broad. It's meant to be all-encompassing. But when you try to go broad and all-encompassing, you, of course, lose the ability to drill down and try to get at some of the particular populations, geographies, service lines that may be strapped, or to understand why a particular service line, geography, community may be experiencing the access issues they're experiencing. So a focused assessment, I think, which is contemplated in our statute, is a really exciting opportunity to be able to drill down and try to think about the particular circumstances of a particular region or service line or geography. I think we are very well aware of some of the particular challenges facing rural communities in Massachusetts. We know very well that services are not equally distributed and that it is our more rural geographies that tend to have fewer resources, even when you count resources on a per capita basis. They tend to be lower generally in some of our more rural parts of the state. So absolutely an important focus and something that I don't think the plan will shy away from.
Thanks, Kara. Really appreciate your thorough answer to our question. We actually do have a question for the foundation, which I will take to give both Bob and Kara a minute to breathe. And that question is just asking about, whether there will be any formal relationship between the foundation and OHARP as you embark on setting up your new office. And the answer, just to clarify, is no. There will be no formal relationship. There is no formal relationship there. But as we have done historically, we will continue to keep each other apprised. Particularly, the foundation will continue to keep OHARP apprised of policy and research work that we have underway that may relate to or support some of the work that is being done. We all want to be intentional about being good stewards of resources and ensuring that we're sharing research work when relevant. So happy to clarify that. Bob, I have a question that has also come up for you. And that question is, based on the history that you covered in this presentation and also in the issue brief, you noted a shift away from a more formal health services planning process and structure. And so I'm curious if you can speak a little bit to what you think is different now in terms of the state reestablishing a more formal process. Again, a little bit speculative here, but what do you think is necessary in order for this to be effective based on what you've learned in looking back? So looking back can inform us how to think about how to move forward, and we'd love some of your insight there.
Sure. Well, so I'm, these things are organic and they ebb and flow with time. I think, right now, why right now? The market doesn't seem to be solving some of the entrenched problems that we've all identified, the access problems, equity problems that Kara raised and that you talked about in your introduction, Caitlin. So that's one that has sort of come to a head, I believe. The steward crisis also seems to have brought some focus to this for policymakers and stakeholders. John McDonough gave me the phrase focusing event, which is really what this is. The crisis and what it caused. It was the result of market forces really kind of run amok. The extraction of the resources from the system by private equity and the real estate investment trust, and it stripped communities of critical healthcare resources without any way to replace them. So I think we might be at a point where market mechanisms are now facing questions themselves about their effectiveness, where historically they kind of replaced the planning efforts. And maybe the pendulum has swung back a little bit now, or at least part way, so that a publicly led planning process can better address some of these issues. What's necessary to make this work? I think I mentioned broad participation, including from communities, equal voices at the table with equal access to information is very important. Buy-in and authentic support from leaders in state government and from major healthcare organizations, which is going to require, because of these conflicting priorities and need for incentives to get people to participate, need to show stakeholders, demonstrate to stakeholders what they have to gain from participating. And then, of course, the long-term commitment. This is not a one-off kind of thing. This should be an ongoing organic activity on the part of all the participants. I can't hear you. I can't hear you, Caitlin.
Oh, let me try again. Kara, can you hear me? Okay, great. Sorry about that. Apparently IT issues are the norm even after many years of doing this remotely. I have one last question that I'm going to ask, and Kara, I'm going to turn it over to you before we wrap it up. And I'm going to kind of combine a couple of the questions that I'm seeing. So we have a couple of questions that are really aiming to get a better sense of, if and what the stakeholder engagement strategy might look like as you begin your work. Will you be reaching out to community organizations who do some of this community needs assessment? Will you be pulling in community health centers, hospital providers, et cetera? And I would just say there's a few different questions on this same theme. So wanted to see if you could speak generally for a minute or two, just in terms of what the stakeholder engagement process might look like as you stand up this work.
Sure, absolutely. Thank you. What an important question. There are already existing structures that the Health Policy Commission uses and that this office will use as well to do some of that stakeholder engagement. So we have our 11-member board, we have an advisory council, we of course have partners at other state agencies, and the statute explicitly instructs us to conduct our work in consultation with those groups. We are also required under the statute to hold at least one annual public hearing as an opportunity to get comments in that way. But beyond that, I think, Bob alluded to this in his remarks. We do think it's incredibly important that we have that perspective, the expertise of the community itself in knowing their access challenges, their needs, their preferences, their priorities. So I would say, in response to some of these questions, yes, if there's work that's already been done that we can leverage, we absolutely want to leverage that. We've already, we've read and are reading the community health needs assessments that are put out by our hospital systems. We're very familiar with those. We have a group of people who've made their way through them in great detail. Absolutely work being done by other local community organizations. We want to know about it. We absolutely want to incorporate that. And then, of course, we'll need mechanisms for new avenues and opportunities for communities to express their priorities and preferences to us. And I don't have details for you yet on exactly what that will look like, but I can tell you it is on our high priority list of things to be thinking about and engaging in. So thank you. So important to this work.
Thank you, Kara. Thank you, Bob. I'm actually going to move us to a wrap up. I want to thank our speakers, both Kara and Bob. I want to thank all of you for joining our webinar today. Please do feel free to reach out to us with any questions. If you'd like to stay up to date on the Foundation's upcoming publications, grant opportunities, and events, we encourage you to subscribe on our email list. We will post a link to the online sign-up form in the chat. Finally, we'd like to ask you to indulge us and take a few moments to respond to a survey that will pop up when we close out. All responses will remain anonymous. We really value your feedback and we use it to shape our work moving forward. So we would really welcome your responses. Thank you very much and have a great rest of your day.